Welcome to Chapter 2 entitled Pharmaceutical Care and the Role of Drug-Related Problems. Identifying, resolving and preventing drug-related problems are considered cornerstones in pharmaceutical care. The Pharmaceutical Care Network Europe, abbreviated as PCNE, defines a drug-related problem as an event or circumstance involving drug therapy that actually or potentially interferes with desired health outcomes. Another term sometimes mixed up with drug-related problems is medication error, defined by the European Medicines Agency, abbreviated as EMA, as an unintended failure in the drug treatment process that leads to, or has the potential to lead to, harm to the patient. The natural dividing line between a drug-related problem and a medication error would then be whether the deviation has been committed by a patient or a health professional, respectively, although there is no full consensus on the interpretation of the two terms. Classifying drug-related problems is desirable for the development of pharmaceutical care practice and research and facilitates documentation and follow-up, important cornerstones of pharmaceutical care. Many different drug-related problem classification systems have been created throughout the years with both similarities and differences. It is of great importance that a drug-related problem classification system is easy to use in daily pharmacy practice, that it is accepted, feasible and validated. The drug-related problem identification rate varies a lot among studies and practices, from less than one drug-related problem per patient to several, depending on a number of factors. Several ways to increase the rate have been tried in different countries. We will begin with an introduction. Detecting and resolving as well as preventing patients' drug-related problems is one of the essential activities of the pharmacist, aimed at ensuring a correct drug use to optimize the therapeutic effect and minimize the possible adverse effect of the patient's medications. Ever since the concept named pharmaceutical care was created and spread, it has been regarded the core of the concept. Next we will look at drug-related problems. What is in the name? The oldest publication including the term, drug-related problems, abbreviated as DRPs, in its title found in a current PubMed search was in the Canadian Family Physician in 1973, but this study dealt with non-medical drug use. That is, with abuse of medications and primarily illicit drugs. The handful publications including drug-related problems in their titles that followed in the 1970s were however on drug-related problems in patients' medical use of drugs, such as adverse drug reactions and non-compliance, as well as about drug-related hospital admissions. But the breakthrough of the use of the term did not come until after the epoch-making pharmaceutical care publication by Hepler and Strand in 1990. Followed by another one by Strand and colleagues in the same year on the structure and function of drug-related problems. The introduction of the concept of pharmaceutical care resulted in an ambition to apply a new philosophy of pharmacy practice, according to its creators Hepler and Strand. Pharmacists must abandon factionalism and adopt patient-centered pharmaceutical care as their philosophy of practice, as they phrased it and continued, pharmacy's reprofessionalization will be completed only when all pharmacists accept their social mandate to ensure the safe and effective drug therapy of the individual patient. Identifying, resolving and preventing drug-related problems are therefore considered cornerstones in pharmaceutical care and have even been labeled as the heart and soul of the practice of pharmaceutical care. The first definition of a drug-related problem read as follows: an event or circumstance involving drug treatment that actually or potentially interferes with the patient's experiencing an optimum outcome of medical care, shortly followed by an undesirable patient experience that involves drug therapy and that actually or potentially interferes with a desired patient outcome. A limitation of these definitions is, however, that a problem would require a negative experience in the patient to be recognized as a drug-related problem. But there are drug-related problems, such as a less optimal effect of the drug treatment due to patient non-adherence, which may even make the patient feel better in the short run, but may have bad consequences in the long run. Siegel's definition, a circumstance of drug therapy that may interfere with a desired therapeutic objective, also includes drug-related problems that the patient may not experience or would not even be aware of and is hence more useful. Based on the previous definitions, the Pharmaceutical Care Network Europe (PCNE) defined a drug-related problem as an event or circumstance involving drug therapy that actually or potentially interferes with desired health outcomes. Other terms used to designate drug-related problems have been drug therapy problems, pharmaceutical care issues, pharmacotherapy failures, and negative clinical outcomes. Drug-related problems are primarily caused by the patient's behavior in one way or another, while medication errors generally are due to faults committed by health professionals, although there is a gray area and a lack of a full consensus among practitioners and researchers. Medication errors will be discussed more in detail in Section 2.2. Nor is there a consensus on what constitutes a drug-related problem and a cause of a drug-related problem, respectively, which will be further elaborated in Section 2.3 on drug-related problem classifications. Examples of drug-related problem categories according to different classifications are therapy failure, adverse drug reaction, drug interaction, contraindication, under- and overuse of drug, as well as untreated indications and drug use without indication. In the PCNE drug-related problem classification, some of these are however categorized as drug-related problem causes rather than as drug-related problems. Pharmacists are in a unique position to identify, correct and prevent the occurrence of patients' drug therapy problems because of their pharmacotherapeutic training and regular contact with patients. In a patient-oriented role, they could, therefore, enhance drug therapy outcomes before they lead to morbidity and mortality. To further demonstrate the meaning of a drug-related problem, the following examples are given. Mrs. Lorraine Johnson, 55 years of age, a regular at your pharmacy, comes to get a first refill of her metoprolol depot tablets 200 mg for her hypertension, prescribed by the new, young doctor at her healthcare center. She thinks, however, that they are hard to swallow, but tells you that she used to split them in half and then chew them carefully. Since years, Mrs. Johnson also takes beclomethasone, Easyhaler, 200 micrograms twice daily, as well as salmeterol, Discus, 50 micrograms, of which she wants another refill, a couple of weeks earlier than expected. There are two drug-related problems affecting Mrs. Johnson's medication. Firstly, depot tablets should not be split and chewed. That is, the patient administers the drug in a wrong way and the effect of the drug treatment would not be optimal. Secondly, metoprolol is contraindicated in asthma patients, or should at least be used with great caution. Apparently, Mrs. Johnson's use of metoprolol was the reason for her earlier refill of salmeterol. Hence, another not optimal effect of her drug treatment. The first intervention by the pharmacist would then be patient counseling, that is, to inform Mrs. Johnson about how depot tablets work and hence why they should not be split and chewed. A second intervention would be to contact the young doctor at the healthcare center to suggest a switch of metoprolol to an angiotensin-converting enzyme inhibitor or an angiotensin II receptor blocker. Miss Mary Anderson, 19 years of age, comes to your pharmacy and presents a prescription of metronidazole tablets 500 mg, to be taken 3 times daily for a week to treat a dental infection. Mary also asks for a refill of her contraceptive pill and is worried that her antibiotic may decrease the effect of her pill and asks you if that's true. She happily tells you about the birthday party she will go to Saturday night together with your daughter and a number of friends in common. In this case, Ms. Anderson is likely to suffer from adverse drug effects if she drinks alcohol, due to an interaction between metronidazole and alcohol. However, metronidazole does not decrease the effect of her birth control pills, as rifampicin is the only antibiotic that does. The pharmacist's intervention would be patient counseling to calm her down about her birth control, but to inform her about possible risks of alcohol intake during her treatment. Mr. Joe Trump, 38, known as the great playboy in town, enters your pharmacy and tells you that the hydrocortisone cream and the plasticizer cream he bought over the counter more than a week ago did not alleviate the eczema on his hairy arm at all. According to his description, he has apparently used the creams in a correct way. So, he wonders whether you can recommend any better cream. Obviously, there is no effect of Mr. Trump's drug treatment despite an apparently correct use, hence a therapy failure. It seems like he would need a stronger cortisone cream on prescription, or that his eczema may even be infected by fungus. So, an appropriate intervention besides patient counseling would be referral to a medical doctor. As indicated by the definitions, a drug-related problem can be either potential, possibly leading to real problems for the patient, or actual or manifest. The problem already impacts the patient and his therapy. Pharmacists have an important role both in preventing potential problems in patients to become manifest and in resolving manifest drug-related problems. Non-prevented, unattended and unresolved drug-related problems may cause drug-related mortality and morbidity, resulting in both unnecessary suffering and huge expenditures to society, due to extra doctors' visits and hospitalizations. The cost of illness model designed by Johnson and Bootman, which estimates societal costs for drug-related morbidity and mortality in the U.S., is well known. Its follow-up by Ernst and Grizzle showed that these costs more than doubled in the span of 5 years. Several studies have been conducted on drug-related hospitalizations, some resulting in a prevalence of 3 to 7%, others in up to 29%. The value of clinical interventions in Australian community pharmacies have been demonstrated both in terms of the quality of care and cost savings. Favorable clinical and economic outcomes of pharmaceutical care in ambulatory patients have also been shown in the U.S. Data on cost efficiency of interventions to reduce preventable drug-related morbidity are otherwise scarce, but it was concluded in a Portuguese study that the economic implications of preventable drug-related morbidity are so great that even expensive interventions to tackle the problem may be cost-effective. In a Swedish study, the potential societal cost savings by community pharmacy interventions on drug-related problems were estimated to be 37 times the expected pharmacy personnel costs for identifying and responding to the drug-related problems. We will now progress to medication errors. The European Medicines Agency, abbreviated as EMA, defines a medication error as an unintended failure in the drug treatment process that leads to, or has the potential to lead to, harm to the patient. Mistakes in the prescribing, dispensing, storing, preparation and administration of a medicine are the most common preventable cause of undesired adverse events in medication practice and present a major public health burden, according to the European Medicines Agency. European Union legislation requires information on medication errors to be collected and reported through national pharmacovigilance systems. In addition, the European Medicines Agency plays a coordinating role and has published a set of good practice guidance. A medication error has also been defined as a failure in the treatment process that leads to, or has the potential to lead to harm to the patient. A simple and to-the-point definition, although it doesn't specify who makes the error. However, it could be any health professional responsible for the patient's treatment. Examples are doctors prescribing errors, pharmacists dispensing errors, and nurses administration errors. Within the U.S. Food and Drug Administration, FDA, Center for Drug Evaluation and Research, abbreviated as CDER, the Division of Medication Error Prevention and Analysis, abbreviated as DMEPA, reviews medication error reports on marketed human drugs including prescription drugs, generic drugs and over-the-counter drugs. DMEPA uses the National Coordinating Council for Medication Error Reporting and Prevention, abbreviated as NCCMERP, definition of a medication error. Specifically, a medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in the control of the healthcare professional, patient, or consumer. Such events may be related to professional practice, healthcare products, procedures, and systems, including prescribing, order communication, product labeling, packaging, and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. Hence, the medication error definition used by the FDA is broader and more comprehensive than the European Medicines Agency definition and overlaps the definitions of a drug-related problem, making it harder to distinguish between the two concepts. Drug-related problems then rather become a subgroup of medication errors. In its document on medication errors, the World Health Organization, WHO, refers to the FDA definition of a medication error and lists a number of factors that may influence medication errors. Factors associated with healthcare professionals include those listed below. 1. Lack of therapeutic training. 2. Inadequate drug knowledge and experience. 3. Inadequate knowledge of the patient. 4. Inadequate perception of risk. 5. Overworked or fatigued healthcare professionals. 6. Physical and emotional health issues. 7. Poor communication between healthcare professionals and with patients. Factors associated with patients include the following. 1. Patient characteristics, e.g., personality, literacy, and language barriers. 2. Complexity of clinical case, including multiple health conditions, polypharmacy and high-risk medications. They also list factors associated with the work environment, with medicines, tasks, computerized information systems and primary-secondary interface. All the factors listed, except for partly the patient factors, are clearly related to the work performed by health professionals. The natural dividing line between a medication error and a drug-related problem would then be whether the deviation has been committed by a health professional or a patient, respectively. The following examples may facilitate the separation between a medication error and a drug-related problem. An error that is not a drug-related problem, or not leading to a DRP, would be 550 mg instead of 500 mg amoxicillin prescribed. A drug-related problem that is not an error is the occurrence of a side effect at normal dose. Drug-related problem classifications are presented and discussed in Section 2.3, and like for drug-related problems, there are classifications of medication errors. Contextual classification deals with the specific time, place, medicines and people involved, while modal classifications examines the ways in which errors occur. It has however been argued that classification based on psychological theory is to be preferred, as it explains rather than merely describes errors. In this way, medication errors can be classified as knowledge-based mistakes, rule-based mistakes, action-based slips and memory-based lapses. Lack of knowledge or ignorance of facts could result in knowledge-based errors, while misapplication of good rules or failures to apply them as well as applications of bad rules may lead to rule-based mistakes. An action-based error could, for example, be a slip of the pen, resulting in a prescribing error. Memory-based errors simply occur when something known is forgotten. We will now discuss drug-related problem classifications. Classifying drug-related problems is desirable for the development of pharmaceutical care practice and research and facilitates documentation and follow-up, important cornerstones of pharmaceutical care. Documenting pharmaceutical care, including drug-related problems, is covered in Chapter 8. The role and structure of such classifications, however, also is important. Reasons for classifying and documenting drug-related problems and pharmacy interventions are several, such as these listed below. 1. Gives a structured and standardized approach to drug-related problem identification and pharmacy interventions. 2. Increases the pharmacist's attention to patients' drug-related needs, resulting in more drug-related problems being detected, managed and resolved. 3. Highlights the pharmacist's role in ensuring the correct and safe use of medicines. 4. What has not been documented, has not been done, hence documentation provides evidence of practice. 5. Fosters continuing education in pharmaceutical care practice through a reality-based educational material. And 6. Makes work more fun. The ultimate purpose of identifying, preventing, classifying, resolving and documenting drug-related problems is to improve the use of drugs in patients and hence their health and quality of life. There seems to be a general agreement on including not only actual or manifest drug-related problems but also potential ones, as drug-related problem prevention is an important part of pharmaceutical care. Ideally, potential drug-related problems are detected prior to becoming manifest and hurting patients. As previously mentioned, there is however a lack of consensus on separating issues identified as causes of drug-related problems from issues identified as drug-related problems. Some may see an issue as a cause of a drug-related problem, such as a drug-drug interaction as a cause of a drug-related problem like therapy failure or an adverse drug reaction, abbreviated as ADR, while others see the issue as a drug-related problem like the interaction in this case and the therapy failure or drug-related problem as a consequence of the drug-related problem. It may be helpful for the separation between causes and problems to decide whether a pharmacy intervention is aimed at rectifying the cause of the drug-related problem or the drug-related problem, and you may even end up in philosophical discussions and perplexities. A number of different drug-related problem classification systems have been created throughout the years, as presented in 2 publications in 2004 and 2014. Respectively. In the first overview, 14 classifications were identified and presented, in the second one 20. Additionally, a number of modifications of previously developed classifications have been used in various studies. The following requirements for drug-related problem classifications were listed in the first publication. 1. The classification should have a clear definition, both for the drug-related problem in general and for each drug-related problem category. 2. The classification should have a published validation. 3. The classification should be usable in practice, has been used in a published study. 4. The classification should have an open, hierarchical structure, with main groups, subgroups and an open structure to include new problems, preferably on subgroup levels. 5. The classification should have a focus on the drug use process and outcome and separate the problem itself from the cause. Additionally, the classification categories should not be overlapping but mutually exclusive. However, as concluded in the second publication, there appears to be no consensus on preference or structure of classification systems. Despite the fact that a large number of classifications have been developed, new ones still appear and a universally accepted classification system still doesn't exist. There are many differences between classifications, such as some being non-hierarchical, others not. Some have a classification of drug-related problems only, such as the initial classification by Hepler and Strand. Others have a classification of drug-related problem causes or interventions as well. The system constructed by the Pharmaceutical Care Network Europe, PCNE, also has a classification of acceptance of intervention proposals and a classification of the status of the drug-related problem, that is the outcome of the intervention. Some classifications have not been published in an international, scientific article but in a national report only. Not all classifications provide a definition of a drug-related problem, and there is in some cases an overlap between the drug-related problem term and other drug safety terms. Some classifications give definitions of the drug-related problem categories, others don't. The number of drug-related problem categories also varies a lot, from 6 up to about 60, including subcategories. Where causes are included in the system, the number of categories may be as high as 35. A few classifications have been used in just one published study, while others were applied in several or up to around 80, as with the Hepler and Strand classification, including modifications. One classification, the Westerland system, was used nationwide in all Swedish pharmacies during more than a decade. To demonstrate the variety of drug-related problem classifications, 3 examples follow. The Hepler-Strand classification, the first established classification, contains a non-hierarchical list of drug-related problem categories and has never been revised. 1. Untreated indications. 2. Improper drug selection. 3. Subtherapeutic dosage. 4. Failure to receive drugs. 5. Overdosage. 6. Adverse reactions. 7. Drug interactions. And 8. Drug use without indication. The Westerland system is non-hierarchical as well and has been revised to some minor extent a few times, resulting in the last 5th version. It contains both a classification of drug-related problems and pharmacy interventions. Drug-related problem categories include the following. 1. Uncertainty about the aim of the drug. 2. Insufficient or no therapeutic effect, therapy failure. 3. Underuse of drug. 4. Overuse of drug. 5. Drug duplication. 6. Adverse reaction or side effect. 7. Interaction. 8. Contraindication. 9. Inappropriate time for drug intake or wrong dosage interval. 10. Practical problems. And 11. Other drug-related problem. Pharmacy intervention categories include the following. 1. Patient drug counseling. 2. Information to patient's representative. 3. Printed information. 4. Practical instruction. 5. Contact with prescriber or other healthcare provider. 6. Switch of drug. 7. referral to prescriber or other healthcare provider, and 8. Other intervention. The most comprehensive classification is the one by the PCNE, contrasted by the previous two by being hierarchical with both primary domains and subdomains. It has been revised several times, the current one being version 8.02. The primary domains are as follows. Regarding problems, P1 corresponds to treatment effectiveness. P2 corresponds to treatment safety. P3 corresponds to others. Regarding causes, C1 corresponds to drug selection. C2 corresponds to drug form. C3 corresponds to drug dose. C4 corresponds to treatment duration. C5 corresponds to dispensing. C6 corresponds to drug use process. C7 corresponds to patient-related. C8 corresponds to others. Regarding the planned interventions, I0 signifies no intervention. I1 signifies at prescriber level. I2 signifies at patient level. I3 signifies at drug level. I4 signifies others. Regarding intervention acceptance, A1 signifies intervention accepted. A2 signifies intervention not accepted. A3 signifies others. Regarding the status of the drug-related problem, O1 signifies problem status unknown. O2 signifies problem solved. O3 signifies problem partially solved. O4 signifies problem not solved. Some classification systems have been validated, others have not. Assessment of the internal validity can be found for the Westerland, PAS and PCNE classifications and are based on case descriptions and questionnaires. Basker and colleagues lists references, where inter-rater agreement and inter-rater reliability measurements have been stated or presented. Several criteria are to be considered in a validation, such as internal and external validity, appropriateness, feasibility and acceptability. A validation is usually performed by presenting a set of patient case descriptions with drug-related problem situations to a number of pharmacists, such as for the Australian document classification system, who then are assigned to find potential or manifest drug-related problems in the cases and classify them according to the actual system. If there are discrepancies between the pharmacist's drug-related problem classifications, there is a room for improvement of the system, unless the case descriptions have not been clear enough. Ideally, the validation test is repeated a couple of weeks later to examine not only possible inter-rater discrepancies again, but also intra-rater inconsistencies. It is important that the drug-related problem categories are mutually exclusive, and that the definitions are unambiguous. Drug-related problem causes, interventions and other possible parts of a classification system can be validated in a similar way. It is however difficult to reach a 100% consensus level among pharmacists in a validation, and a conformity of 80% may be acceptable. It is of great importance that a drug-related problem classification system is easy to use in daily pharmacy practice, that it is accepted and feasible. Hence, it should be constructed in a logic way with the actual category easy to find for a pharmacy practitioner, even in a common stressful situation. The Hepler, Strand classification and the Westerland system have been used extensively in daily practice, both non-hierarchical with few categories. Too many different categories may then pose difficulties. However, one way to handle a hierarchical system with many categories such as the PCNE classification is to only use the primary domains in regular, daily practice and include the subdomains just during limited periods of time or for one or just a few therapeutic categories at a time, e.g., patients with drugs for hypertension, diabetes or depression. The drug-related problem identification rate varies a lot among studies and practices, from less than 1 to several drug-related problems per patient, depending on a number of factors. Several ways to increase the rate have been tried in different countries. In Australia, electronic prompts or pop-up alerts in dispensing software, appearing when filling prescriptions for selected patient groups, have been used. An interventional program aimed to increase the rate of clinical interventions has also been undertaken in Australian community pharmacy, including both education and professional remuneration. A communication technique with so-called pharmacy-based protocols has been used in Australia. A similar technique has been tried in OTC drug consumers in Denmark. In Sweden, so-called counseling models, or protocols, have been used in a series of studies. They consist of a number of key questions to be covered routinely in the pharmacy practitioner's dialogue with the patient, questions which are often brought up in patient encounters, but are asked in a more consistent way to all patients within selected therapeutic groups. The number of detected drug-related problems was superior in pharmacies practicing counseling models compared to both blind and open controls. Commitment among pharmacy practitioners to the drug-related problem identification, resolution and documentation is often decisive for the rate and may even overcome possible time constraints. The implementation of medication reviews is another means to facilitate drug-related problem identification and usually results in a much higher rate than in regular pharmacy practice, especially if also clinical patient data are available. See Chapter 6. Thank you.